Assalamu alaikum, Dhaka. My name is Dr. Laya Sriram. I'm, just to correct Farhan, I'm not an airway expert. I'm still taking baby steps in airway surgery. It's a daunting task to go after my mentor, Dr. Thirunavukarasu. I'm going to try. I am a pediatric ENT and airway surgeon practicing in Coimbatore. After I did my fellowship in pediatric airway surgery under Dr. Thirunavukarasu and the Laryngology and Voice Association of India. The ladies of India, we share a very special fondness for Dhaka because we all treasure the Dhakai Jamdani sari. So it's a great matter of joy for me to be wearing a beautiful sari from this land and to present before you all. So let's get started. I'm going to be talking about Laryngomalacia. So Laryngomalacia, there are several postulated theories that talk about Laryngomalacia, and the first one of the possible reasons could be a congenital flexibility of laryngeal tissues. Another reason could be the deficiency of laryngeal adductor reflex, and laryngopharyngeal reflux is also attributed towards causing laryngomalacia. So whatever the pathogenesis may be, we know that in laryngomalacia there is an inward collapse of the supraglottic structures on inspiration. So the diagnosis is done by awake transnasal fiber optic laryngoscopy. So in our setup, we like to do it, just one moment. Yeah, so in our setup, we like to do it in the OR. The patient is awake. That's the flexible fiber optic laryngoscope being passed through the nasal cavity. And we like to examine the nasal cavity, the nasopharynx, to look for any adenoid because it can also add to the problem that the patient is having. And in a number of cases, there is also pharyngomalacia, so we like to look for pharyngomalacia as well. And here we can see the larynx, the epiglottis is sort of leaning towards the laryngeal inlet, and we can see the aryepiglottic folds being shortened and the tall arytenoids. We can also look for any reflux that happens and any aspirations that happen spilling into the larynx. So, okay, so from 2014 until 2023 in Dr. Thiru's unit, which is where I worked, there were 1,112 transnasal fiber optic laryngoscopies performed, and Laryngomalacia was found to be the most common airway pathology. 178 patients were diagnosed to have laryngomalacia. Not all of them underwent surgery. Not all of these patients had to undergo surgery. So what are the indications for surgical intervention in laryngomalacia? Like I said, 80 to 90% of the patients have only mild laryngomalacia and they just get away with watchful observation. So when there is severe stridor, there are acute life-threatening events, apneic spells or cyanotic episodes, when there are feeding difficulties, recurrent aspirations, there's failure to thrive, there is obstructive sleep apnea, severe suprasternal retractions or recorded hypoxemia, then these are all indications for the patient to undergo a supraglottoplasty. So in our series, from that 178 patients who were diagnosed to have laryngomalacia, 61 patients had to undergo surgery. The symptomatology we saw in those patients, if you look on the rightmost column, is the percentage of cases. So 86% of patients had chest retractions, 72% of patients had feeding problems, 68 had respiratory distress, and 63% had failure to thrive. Luckily, apneic episodes and cyanotic spells were common in a far lower number of patients. So when there are feeding problems in these patients, we also do a FEES before we go on to operate on the patients. So here we see a FEES being performed. There is already a nasogastric tube which indicates that the patient had a previous feeding problem. And we can see the epiglottis, we can see the laryngomalacic features here, the epiglottis being curled and tubular. and a tight supraglottis, and we can see some penetration happening into the larynx. So laryngomalacia is also associated with other conditions, like in seven of our patients had an associated GERD. This number could be more. We had Pierre-Robin sequence in 6 cases. Other synchronous airway lesions like a lingual thyroid, cysts, all the way to laryngeal clefts were seen in 6 patients. 3 of our patients had facial dysmorphism, and 37 patients did not have any other comorbid conditions. So in this slide, I'm not going to describe the types of laryngomalacia, but I just want to state that type 1, type 2 and type 3 does not indicate that it is in ascending order of severity, but it is 3 different types of surgical techniques that need to be used for each of these types of laryngomalacia. So going on to the management, laryngomalacia supraglottoplasty requires a very nuanced kind of anesthesia. So the most ideal would be a total intravenous anesthesia where there is no ET tube in the way of the surgeon, and the patient is breathing spontaneously. This of course requires a highly skilled anesthetic team that has been operating with the surgeon for a number of years. And the next preferred technique would be apneic anesthesia, where the patient is ventilated to reach 100% saturation, and then in an apnea, in a period of apnea which lasts for about a minute, one step of the surgery or one side of the supraglottoplasty is done, and then when the saturation starts dipping, say 95 or so, the surgeon inserts the tube through the Parsons laryngoscope, as you can see in this picture, and then the anesthetist connects the circuit, and the patient is ventilated back to 100%, and then the tube is taken out, and the second step is carried out, and so on. When this is too complicated for the anesthetic team to do, when they are not, when they feel like they can't do these things, then we go with a conventional per-oral or a nasotracheal or tracheal intubation. So this is what I had talked about. In apneic ventilation, there is also a second tube in the nasopharynx that provides high flow oxygen. This is a technique that's a recent development that came up in 2015. It is called Thrive Transnasal Humidified Rapid Insufflation Ventilatory Effort. Exchange, right. So it never sticks in my mind. So the basic principle of this is that when you give high flow humidified oxygen through the through the nose, it washes out some of the carbon dioxide and helps prolong the apneic period and gives us a little bit more time in the apneic period to carry out the surgery. So when the saturation starts falling, this is the ET tube going in to ventilate during that time. The surgeon inserts the ET tube, and the patient is ventilated to 100% saturation, taken out, and then surgery starts. So this is type 1 laryngomalacia. The defect is an inward collapse of the aryepiglottic fold during inspiration. So here you can see cold steel instrument, the scissors used to cut the divide the aryepiglottic fold. This is the first step that is done. You can also see the tall arytenoids and the cuneiform cartilage, and very short aryepiglottic fold that is being divided. It is very important to avoid injuring the pharyngoepiglottic fold. You can see on either side of the epiglottis coming towards the end of the image. Those are the pharyngoepiglottic folds. Those need to be preserved so that aspiration doesn't happen. You should not go near the interarytenoid mucosa, because this will cause a posterior glottic stenosis, and of course damage to the endolaryngeal mucosa should also be avoided. This is type 2 laryngomalacia. In addition to what we saw in a type 1 laryngomalacia, there is also a curled tubular epiglottis. So here, this is an extension of what we saw in the first slide, after giving those cold steel cuts, a coblator is used to bust down the cuneiform cartilage and also create an incision along from the cuneiform arytenoids all the way up to the base of the epiglottis, while not touching the pharyngoepiglottic fold or the interarytenoid mucosa. Different instruments have been used for this in different centers. People use lasers, people use microdebriders, but in our setup we find the best results with coblator and microlaryngeal wand. In this, a small rim of epiglottis is also ablated and vaporized. Unfortunately, I don't have a clipping for that. This is type 3 laryngomalacia. Here, the overhanging epiglottis collapses into the laryngeal inlet, causing obstruction on inspiration. And in this type, the laryngoscope is placed. What we want is to pull the epiglottis forward towards the tongue, away from the laryngeal inlet. So we create a scar in the base of the tongue and the anterior surface, lingual surface of the epiglottis. For this, the laryngoscope is placed 1 centimeter proximal to the vallecula and a wound is created. Half of the wound is on the tongue base, half is on the lingual surface of the epiglottis, and this causes a cicatricial reaction over time and pulls the epiglottis forward. So in this particular case, an epiglottopexy, a suturing was also done to ensure that the epiglottis stayed closer to the tongue. So you can see the suture going through the base of the epiglottis. You can see the median glossoepiglottic fold and the suture being taken there. And this is the same case that the epiglottis was flopping in. Now after the type 3 laryngomalacia surgery and the epiglottopexy, the epiglottis is nicely pulled forward and the laryngeal inlet is free. Post-operative care, since most of our patients right now, they are not intubated, the patients are not, they just come out, and in case the patients are intubated, they are extubated on table. Where we like to keep them intubated is when we do the surgery for type 3, where we create that wound and we want the a little bit of stenting to keep that epiglottis placed forward. Then we put in an ET tube for 48 hours to function as a stent to keep that epiglottis stuck to the tongue base. All patients are admitted to the PICU for about 48 hours and oral feeds are started from the first post-operative day. For type 1 and type 2 surgery, since there is very minimal mucosal damage that is done, they don't require antibiotics. But in type 3, because we create a slightly larger wound and there is possibility of infection of that wound, we put them on antibiotics for 5 days, and all patients get proton pump inhibitors for about a month post-op. So in our center, we found that 90% of the cases resolved completely, and about 9% of the patients did not improve. These patients were found to have either associated neurological diseases or were found to be syndromic. So that's about it. Thank you.